I click on it, here's the codes that go into it. Inpatient visit, emergency room visit, emergency room and inpatient visit. He says that event has to start all days before to 0 days after, and between 0 days before and all days after. Basically, it's a complex temporal logic that says the condition of myocardial infarction should happen sometime during an inpatient stay. It can happen on the start date of the inpatient, it can happen during the inpatient, but it has to happen before the end of that inpatient visit. He also has additional rules here, which he has applied on inclusion criteria. In inclusion criteria, he says, you should have exactly 0 of acute myocardial infarction, the same rule on the top, with the inpatient visit in the past 365 days. So he says, if you had a myocardial infarction in the 365 days prior and you received an inpatient hospital stay for it, you are not allowed to enter. So that's the cohort definition that Patrick has implemented for us to evaluate. There is an exit criteria. That exit criteria is fixed. It says, the person will exit 1 day after they enter. So everybody is thought to have myocardial infarction for 1 day and 1 day only. That's because Patrick assumed that myocardial infarction is 1 day, and that is valid because it's an acute disease. So that's what we're going to start with. That's the prelude for the conversation that we're going to have, which is evaluation. Oh. If you go to the Atlas instance, it is cohort ID 25, I believe. They can't see the slides?
This screen is not working.
Oh.
But they're working on it.
It's the same slide that is on odyssey.org. If anybody loves Aza here? So thank you everybody for coming. So we're going to be talking about phenotype evaluation. My name is Gowtham Rao. My collaborator is Aza Shaibi, who also happens to be my wife. So welcome everybody. We're going to be talking about 2 clinical ideas here, myocardial infarction and angioedema. Aza and I lead the Phenotype Development Evaluation Work Group. Please join us. We're going to try to make every attempt today to convince you that we are an engaging group of people that want to build phenotypes. So please join us. So what are we going to do today? The success of this 50-minute session is, by the end of this, you all will be able to recognize the presence of misclassification errors in the phenotype. You will understand errors and how they may cause bias in the study results. And you'll start thinking about how you can fix them. That's the goal, that's success. So, how are we going to do this? There's going to be 10 minutes of theory, and I'm going to talk about measurement errors and our phenotype evaluation workflow. That's the best practices that we have developed in the Phenotype Development Evaluation Work Group, so to build reproducible cohort definitions. We're going to walk through the 2 examples. We're going to use the framework in medicine. See one, do one, teach one. So you are going to see one, I'll do it live. Then you are going to do one, and then we expect you all to teach one.
Everybody got the handout. We distributed handouts.
There should be handouts on the table. Not everybody has a copy. We have limited printouts. All right. So the key idea that we are going for is misclassification errors. What is misclassification in observational research? Misclassification in observational research is to wrongly assign a person to either have or not have a phenotype. Those misclassification errors are of three main categories that we think of. One is the sensitivity errors, two, specificity errors, and in an important new one, index state misclassification. So let's start with sensitivity errors. We say that a given cohort definition has sensitivity errors if we observe evidence that there are persons in our data source who may not have the phenotype of interest. Let me start over. I think I missed that. We may say that a given cohort definition has sensitivity errors if we observe evidence that there are persons in the data source who may have the phenotype of interest but are not in our cohort. So in this cartoon, you have about 32 people. The first half, the colored people, have the phenotype of interest. But our cohort definition has only identified the blue people. So it is missing 4 individuals, and that's an example of sensitivity errors. Specificity errors. We may say that a given cohort definition has specificity errors if we observe evidence that subjects in the cohort do not have the phenotype of interest. So in this cartoon, the upper half has the phenotype of interest, but our cohort definition has identified more than the upper half. Those 3 additional individuals are wrongly identified to have the phenotype of interest. That's an example of misclassification error. And the third one, the important one, is the index date misclassification. This is novel. This is new for most of us. So I'm going to start with an example. Let's say a person received care because they had chest pain. They were taken by the ambulance. They went to the ER, and there an EKG showed ST elevated myocardial infarction. They were taken to the cardiac cath lab. A stent was placed. They had ST elevated myocardial infarction. But the patient recovers over the weekend. On Monday, there was a code entered, and that on Monday it said, condition start date, Monday, myocardial infarction. So you build a cohort definition on it. The data says, the code says, the person has myocardial infarction on Monday. The procedure code says, stent was placed on Saturday. That is an index date misclassification. So a cohort definition that indexes on a condition occurrence of myocardial infarction will say that the start date is Monday, but the procedure was done on a Saturday, which is the true date of myocardial infarction. Why is that important? Because it can bias our studies. So in OHDSI, like I said, a cohort is defined as a continuous period of time that the person has the phenotype of interest. So we have a wrong cohort start date in this particular scenario. The definition of index date misclassification is, we may say that a given cohort definition has index date misclassification error if we observe evidence that subjects identified in the cohort have incorrect designation of event start date. So what we are going to be talking about today is slightly different from fee evaluator. Fee evaluator will not be discussed in today's workshop. There is a workshop tomorrow conducted by the Phenotype Development Evaluation Workgroup where Joel Swerdell will spend more than an hour talking about fee evaluator. You're welcome to join us, and we'll be talking about how fee evaluator will help us quantify sensitivity, specificity, positive predictive value, and negative predictive value for a given cohort definition. But there is something missing in p-evaluator. P-evaluator does not tell us about the origin of these errors. It does not tell us why there are sensitivity errors. It does not tell us why there is specificity errors, and it does not tell us why there is index state misclassification. In fact, p-evaluator does not do index state misclassification. So that's the focus of today's conversation. We're going to look at an instantiated cohort and look for sensitivity errors, specificity errors, and index state misclassification. Why is this important? Why is knowing errors important? We are working on imperfect data. Observational data was captured for billing purposes, for providing clinical care. It was not captured for research. So if we build a cohort definition on imperfect data and don't look at the people that were identified by that definition, then we may be studying a wrong subset. What if, in this example, instead of finding people who have an acute MI, we are finding people who may have an old MI and are getting a follow-up visit in a cardiologist or some other cardiac-related workup. So we want to see if the population that were identified truly fits the target. And the target is described by the clinical description, the clinical idea. If we are blinded to these errors, then our results, whatever study we do, is not valid. We need to anticipate, by looking at measurement errors, we can anticipate biases. And if the bias is too much, then we can make a critical decision. Maybe we should not be doing that study. An indicator of a good quality research is the ability of a researcher to identify bias and do steps to reduce them. And that's what we're doing here. We are trying to reduce bias in our study. So now I'm going to talk about our process. The process was developed by the Phenotype Development Evaluation Work Group. We have an input and we have an output. The required inputs for phenotype development is a clinical description. Everybody in the room should have a shared understanding of what that clinical idea is. What is the profile of the person that are identified by the algorithm? Because only then can we evaluate that the persons who are identified truly have that characteristics. So there's several sources that can help us with that. Clinical expertise, clinical knowledge can help us. Prior knowledge from literature can help us. Reviewing an authoritative source like a textbook can help us. The output is cohort definitions. In the middle is our process. The process takes Ashish showed us how to build the cohort definitions. I'm going to talk about the second part, which is cohort diagnostics, where we will test these cohorts and make decisions. Do we want to change that definition, or do we accept it as is? Do we want to change because there are some errors that we can correct? And that's an iterative process. So now we'll talk about myocardial infarction. So everybody has some sense of what myocardial infarction is. The structured way that we propose that we represent a clinical description, a clinical is to have components like presentation, diagnostic evaluation, therapy plan, prognosis. Presentation for acute myocardial infarction is usually a new onset severe angina, which is more than usual. Diagnostic evaluation may include things like electrocardiogram, maybe other imaging modalities. The therapy plan will include nitroglycerin, aspirin, anticoagulants, beta blockers. Most people will be hospitalized, or everybody should be hospitalized. And then there is the test for cardiac biomarkers, which is an indicator of cardiac muscle injury. They may get a definitive therapy like a percutaneous coronary intervention or even a coronary artery bypass graft. And the prognosis, most people will recover in a few days, and this clinical event may reoccur. Now that's the clinical description. But what we are looking for in phenotype evaluation is components that make our confidence in this algorithm stronger. That is, it strengthens our confidence. And we are also looking for elements that make us believe that this is a bad cohort definition. So we call this as strengtheners and disqualifiers. And these ideas have been documented by the Phenotype work group in the Phenotype library GitHub repository, and I've posted the link there, which you can click through and see at a later date. So what are the strengtheners for myocardial infarction? It could be symptoms and signs, some complaint of chest pain, dyspnea, shortness of breath, palpitations, sweating. It could be diagnostic evaluations like we just talked about. What is a disqualifier? Most people would agree that if you have a strong pleuritic chest pain where when you take a deep breath, it hurts, that may not be a myocardial infarction. There may be other rare conditions that are usually, you don't expect it to happen at the same time. Maybe an aortic rupture. If somebody has a documented aortic rupture on the day of a myocardial infarction, they probably had aortic rupture and not myocardial infarction. Those are elements that we kind of think about as disqualifiers. So we take the cohort definition that was built in Atlas, and I showed you the cohort definition. It's cohort ID number 25, I believe. We instantiate that cohort, and we run this software called Cohort Diagnostics. Cohort Diagnostics runs a set of characterization on this cohort, and it presents a list of diagnostics. The screenshot here shows the several diagnostics presented by Cohort Diagnostics. We have orphan concepts, cohort counts, incidence rate, time distributions, inclusion rule statistics, index event breakdown, visit context, cohort overlap, cohort characterizations, and compare characterization. So we're going to go through them today. So let's do the evaluation.
You can follow up with Gowtham by whether it's on the app, like
Okay. So the way to go there is data.odyssey.org, and there are many Shiny applications there, and one of the Shiny applications here is OHDSI2022 CD tutorial myocardial infarction. The full URL is on the paper handout that was given to you. And on the slides. All right. Okay.
Don't go crazy clicking lots of things and crash it out loud.
That's right. Yeah, that
You can break it, Gowtham. That's your job, right?
it's my job to break it, but I also have to make sure that it will work. So I have a backup plan now that you have brought it up, but I don't need the backup when it's working. Okay, so we are on. Okay, everybody on the data.odyssey.org Shiny application? Okay, so this is the landing page for the Shiny application, and you see two cohort definition. We are interested in the cohort definition number 25. Now, 26 is an advanced version of the tutorial. If we have time at the end, we will visit number 26, but right now we'll just focus on 25. So I'm going to orient you to the Shiny application as the first step. On the left-hand side, you see the list of diagnostics that I showed you in the PowerPoint slide. I can click through. Right now, we are in the cohort definition section. If I click on the cohort ID number 25, and it is not working, Gus.
okay, never mind. Only Gowtham on that.
No. That's fine.
Some people have okay, so while you figure this out, just make sure that everything is let's ask. So we created the cohort, we had the database that Claire told us about, and you saw how it was ETL. Now we have a definition that we implemented on this data to create a cohort. So now we have a table in this data that has all the people who met the criteria for this cohort. Now we generated all kinds of descriptive statistics that anybody
Backup plan.
can think of and put it on my app. And so all of us now can look at characteristics of the people who made it through that cohort definition in that
Yeah.
If not,
All right.
then we have to do something else.
All right, so I'm going to walk you through the user interface as the first step. I have a local instance of Cohort Diagnostics run that is completely out of reach for you guys, so this should be a stable environment. So if I click on the cohort definition, I can toggle through certain sub tabs, which gives me additional details about this cohort definition. The first step is for me to just look at the human readable version of it. Like, what was the rules that went into this cohort definition? What you see over here is another version, a rendering, a text rendering of the rules that was what was in Atlas. Here you see the cohort entry event criteria was a condition occurrence of acute myocardial infarction, which is the same idea that was in Atlas. We have restrictions of the visit to an inpatient or ER, which was in Atlas. We had inclusion rules that you should not have acute myocardial infarction in the 365 days prior. And we had an exit criteria. So this particular page shows us the definition. There are additional components here that, such as the exploring the concept set. So you may want to know what individual codes went into the definition. So here's the acute myocardial infarction, and I can look at the concept set expression. Remember, I showed you the concept set expression before, which is you can enter if you have myocardial infarction and its descendants, but not the codes that had old myocardial infarction has been excluded. So we talked about that. So now we're going to go through the diagnostics. The first step is cohort counts. In the data source that you all have access to, when this cohort was instantiated, there were 38,626 unique persons, and those persons had 40,395 events. What is that telling us is there are some persons in the data source who had myocardial infarction more than once by definition. So we have an incidence, we have about 1.05 records per person. And the question that you want to ask yourself is, does that make sense? Do you expect myocardial infarction to happen about 1.05 times per person, or is it 10 times per person, or is it 50 times per person? What is the expected recurrent events for myocardial infarction? And I think most people would agree that myocardial infarction does reoccur, but it's probably in this range that we are observing. It's like 1.05%. But if you observe that the event rate was 10 events per person, we would be like, there is something wrong with this definition. Agreed? Yeah. So that's what we are going for. We are going for strengtheners. What will increase the confidence? Remember, again, we are working with imperfect data. So the people that were identified by the algorithm may have be completely different from the clinical idea that we are targeting. And if we don't look at these characteristics, then we may be studying the wrong subset. That's what we're trying to avoid. So the next diagnostic I'm going to go is what is called as incidence rate analysis. As I'm generating the plot, I'm going to demonstrate the UI for all right, that's the local instance. I will install packages. No, this is just my local. I never worked on this local. Okay. There you go. And there you go. And we go to incidence rate. And we go. Unselect myocardial infarction. All right. So as we're generated the plot. Excellent. All right. On the top section here is a plus sign. If you select that, it will describe to you what this diagnostic is. What is the computation behind it, and how can you infer from this? So incidence rate analysis here is a diagnostic that has computed the incidence of myocardial infarction, stratified by calendar years, stratified by gender, and stratified by age. I can deselect certain criteria here. So right now, I'm going to deselect age, and I'm going to generate the plot again. there are some filters in this diagnostic. So the data range in our data source, the IQVIA Pharmatric plus 5% sample, ranges from 2014 to 2022. This plot here shows us the data plotted, the incidence rate plotted from 2014 to 2022. There are two colored lines here. The green represent the gender male, and the orange represents female. The y-axis represents the incidence rate. Here, what we are observing is year to year, from 2014 to 2022, the incidence rate of myocardial infarction appears to be stable. It is consistently higher among males compared to females. Now we want to think about this and say, what does that mean? Do you expect wide variations in the incidence of myocardial infarction from calendar year to calendar year? No. So you would expect it to be pretty stable because it's a disease that people have, and how about the gender difference? Any clinicians have an opinion on that topic? So if you look at the literature, go ahead.
Yeah, your primary diagnostic condition for acute myocardial infarction in the paper in the male presentation of TB testing, something like that, as opposed to taking into account the biological differences of research and between genders. That's like research based on out of Noemi Al-Haddad's group, saying that could be a thing.
So you're saying that myocardial infarction is likely more to be diagnosed among men because of the way it presents?
Yeah, males may present more on chest pain, and females might present differently.
That's right. That's right. And that was one of the talks at the main symposium presentation yesterday, which is there is difference in the presentations of male and females, and women are known to have more atypical presentation for myocardial infarction that might impact their diagnosis also. So we observe that in the data.
And people who know the epidemiology of myocardial infarction and cardiovascular disease, do we know that it's true that what we observe here is males are at higher risk? Now, knowing what we know about the epidemiological trends of myocardial infarction and cardiovascular disease, if anybody knows anything, is that true in studies in population? Are males more likely or at higher risk of cardiovascular events in general? Who has any background? Anybody?
In general, yes, but after age 65, females tends to.
That's right. So we have an answer. That is, in general, yes, men tend to have a higher risk for myocardial infarction, but after a certain age, that difference kind of comes together, and that's hormonal reasons, correct? Okay. So now, this visual makes sense. It is in agreement with our prior expectations. So we do not have any concerns so far. Everything is feeling good, correct? Everything is awesome. I'm a Lego dancer.
The other thing you can observe here is a nice straight trend that tells you something about the definition. One of the things we expect that if our definition is good, it's supposed to be stable over the years. If you see up and down, this means that whenever there's a difference in the data is captured, this definition is giving you a different incidence, which is problematic. So generally, the incidence of diseases among a particular population is generally stable, and that's what you expect for a definition. So it's nice to see a stable line.
Yeah.
Sometimes we see a big uptake and a drop.
Yeah.
You know, in US, when that happens in 2015, 2016, any ideas why you would see a change in that trend in 2015, 2016?
ICD
Like the
version.
entire US population changed their. Exactly. It's a change between ICD-9 and ICD-10.
So,
Change data
yeah.
manifest. We don't like that. So if you see it stable, you feel good.
So I changed the parameters here, and I added the age strata. And what you're observing here is 9 different subplots stratified by age decile. So 0 to 9, 10 to 19, 20 to 29. and all the way to 80 to 89. For each age decile, there is an incidence rate that starts from 0 and goes all the way almost to 20 to 25. What the observation here is the incidence rate of myocardial infarction increases with age. And the difference between gender, male and female, tends to continue over the age deciles, which is slightly different from what we discussed, which is our gentleman here said at an older age deciles, you expect the difference between males and females to come closer to each other, but we are not observing that in our data source. So that's a flag for us. We just have to keep that in the mind and say, okay, is that a concern? Is that a bias? Is that an error here? The second issue that I observe here is in the age strata of 70 to 79, there is a dip. Why is there a dip? We have to ask that question. We expect a good diagnostic is a stable trend over calendar years. If there is a change, especially like this, where there's order of magnitude, it starts with 15 and then it goes to 5. So it goes from 15 to 5. That's like 3 times decrease. We have to ask the question, is something wrong here? Now, in this case, this is not because of the ICD-9 to ICD-10 change that was discussed, because this manifests in the calendar year 2017. The ICD-9 to ICD-10 change happened in 2016, where we still continue to see a relatively stable change. So this is an unexplained thing that is not explained by the ICD-9, ICD-10 change. We need to put that take a note of this and say, I have a concern here. We need to investigate this further. Potential bias. That's it. All right. So let's go to the next one. The next diagnostic is what is called as index event breakdown. If I click on the description for it, it will tell me that it is concepts in the concept sets in the entry event definition that are observed on the index date. So concepts in the concept set of the entry event definition. The entry event definition concept set was myocardial infarction. When that concept set expression gets resolved, we have several concept IDs, and which of those concept IDs was present mostly in the population. I'm going to select standard concept just for simplification. This diagnostic can provide us records and persons, so we are just focusing on the persons here. Records, remember, we have about 1.05 records per person. We have about 39,000 people. The counts by concept ID that was present on the index date, 21,000 people of the 39,000 had acute non-ST segment elevation myocardial infarction. 8,000 people had acute ST segment elevation myocardial infarction. Then there are other concepts like acute subendocardial infarction, myocardial infarction due to demand ischemia, and so on. But they start trailing off. But it starts to make an impression on us. All right, so first is the division between ST segment elevation and non-ST segment elevation. When you're doing the phenotype and when you build the clinical descriptions, we would agree that there is something called ST segment elevation and there's a non-ST segment elevation. And we would know the prevalence of non-ST versus ST elevation. ST elevation is relatively less compared to non-ST elevation, and that's what we observe in the data. We observe that the non-ST elevation was 3 to 4 times that of ST elevation myocardial infarction, which is in line with expectations. So you would have done your homework, and that homework would have said ST versus non-ST, and this is the proportion. What it's also telling us is the granularity of the data. So it tells us what level of granularity is captured in our data source. The next diagnostic I want to go through is something called as visit context. Now, visit context tells us the care experiences, the visit experiences of the individuals who are in our cohort on and around cohort start date. We have constructs called before, during, simultaneous, and after. So before is what happened before cohort start date. After is what happened after cohort start date. The during and simultaneous are what happened on or during cohort start date. So during, which visit the myocardial infarction happened during which type of visit. So visits can be more than one day. So it can happen during a visit. And the other is simultaneous. The visit started on the date of myocardial infarction. So the difference here to think about is, did it happen during an inpatient stay? Because inpatient stay can be more than one day, or at the start of the inpatient stay. In this example here, we are observing of the 39,000 people, 28,000 were admitted inpatient visit, and they had myocardial infarction on the date of their admission. But 2,300 had myocardial infarction during inpatient visit. So it's telling us something about a relationship, is it, maybe it's telling us something here. It's telling us that some people may have had myocardial infarction during an inpatient stay. They didn't go to the hospital with a myocardial infarction. We don't know. We need to understand what the data source is and how the data capture processes has happened. But the diagnostic is telling us, look, there is a disconnect here. There is some people that that had myocardial infarction during their hospital stay. So we note this down and think about it later. That's a potential error. Remember, we are working with imperfect data. There is error. All we are doing is surfacing these errors and making sure that we can, thinking of whether we can correct for those. The next diagnostic is the cohort characterization. This is an important diagnostics. So I'm going to pull up the content for it. But as I do that, I'm going to ask you all to look at the here.
So when Gowtham pulled this up, you're going to see now a gigantic table. What this table is, it is giving you the distribution of every concept in the database. Visits, measurements, procedures, conditions, all these elements in the data that exist on the database. It's giving you the breakdown of these events of everybody who made it to the definition, so all the 56,000, the distribution of these events before index, on index, and after index. So now you can explore every event, every code that exists in the database for these people around that index date. So that can give you a lens of what is happening to these people around that time that you put the label on them, say that they had a mind. All the data. We don't pre-specify anything. We're not saying, I want to look at the conditions, or you're having everything, and it's on you to go down and now start looking at what is happening, to have a sense if these are the right people you expect, or if there's some false positives, or there are people that you're missing.
Yeah, and it's not pulling up. So okay, it might come up. All right, so I'm extracting data there, but this is a PowerPoint slide that will help us structure our thinking even further. So as we look at the characteristics, the population level characteristics of the persons that are identified by this cohort, there's a few ideas that we think about. We think about risk factors. What are the risk factors for myocardial infarction? Risk factors for myocardial infarctions could be hypertension, diabetes mellitus, hyperlipidemia, tobacco consumption, coronary atherosclerosis. When do we expect these risk factors to be present? We expect these risk factors to be present before they had myocardial infarction. In what time frame? In the time period between, in the 1 year period prior. The next segment here. We also expect certain signs and symptoms and diagnostic workup, therapeutic treatments. When do we expect to see them? We see them very close to their myocardial infarction, maybe in the 1 month before to 1 month after. Things like chest pain, critical care, ambulance use, EKG, cardiac enzymes check, catheterization, echocardiogram, use of aspirin, clopidogrel, nitroglycerin, presence of shock, cardiac failure, and arrhythmias. We require them, and we try to see if these attributes are present around the time of their myocardial infarction. We look for elements that invalidate their diagnosis. Pleuritic pneumonia, aortic rupture, cardiac transplantation, history of myocardial infarction. We look for items that say maybe their date of diagnosis is actually misclassified because they had a percutaneous coronary intervention one day before. So they have index date misclassification. These are the items that we look for in our large-scale characterization. And it's still loading. Okay, so backup for the backup is PowerPoint slides.
Question.
Yes.
Go back to one. Oh, yeah, this slide. Why simultaneous has higher number than during?
So simultaneous is cohort start date of myocardial infarction, equals to visit start date, inpatient admission date. That means majority of the people here, almost 90%, are being admitted on the date that they got diagnosis for myocardial infarction, which is a good thing. We observe a small number of people during. That means their diagnosis of myocardial infarction happened between their admit date and discharge date.
But not on admit date.
Not on admit date. That's correct.
It's the difference between day 0 and being past day 0.
Thank you.
Yeah. All right. So backup slide. So, so the first thing that we look for is risk factors. In risk factors, there's a large table that gets pulled up by the app. That app will have every code that was ever entered for the people that were identified in that cohort. I'm filtering by an analysis type called condition occurrence, and it is sorted by the occurrence of these codes on day 0. So every row is a code. There are 3 time periods that are described here. On the rightmost corner is on the day of myocardial infarction. The one before is all days starting minus 365 days, 1 year, up to the day before myocardial infarction. And then the other one is all the days before, minus 365 days before 1 year, including the day of myocardial infarction. So 3 different time windows to look at the persons. It is sorted by the last column, which is day 0. And what we observe when we look at this is the items that we talked about are risk factors. The tool automatically brought up a list of elements that are risk factors for myocardial infarction. So you have, it was sorted by the tool. Essential hypertension on the top with a 0.5 or 50% of the people had the diagnosis of essential hypertension on the date of myocardial infarction. We have hyperlipidemia. 40% of the people had hyperlipidemia on the day of. We have chest pain, atherosclerosis, type 2 diabetes, dyspnea, congestive heart failure. All of these attributes you would expect should be present in persons with myocardial infarction, and the tool has sorted it and shown us that. That makes me feel good. This is a strengthener. This feels like this is identifying the right set of people. I'm doing a population level case review right now. It makes sense to me. Next, I'm going to go now fish for items that I want. I'm going to search in the tool. I'm going to just type chest. When I type chest, it brings up chest pain. 50% of the people had chest pain. I type dyspnea. 10% had dyspnea. I start typing critical, and then 40% had critical care related encounters. I type ambulance service. 30% had ambulance service. All of these start making sense. I feel good about this phenotype. This is good. This is the right type of profile of people. When I look at the procedures, so I change the domain from condition to procedures, and then now look at EKG. 60% of the people had EKG. I expected this, and I observe it. This makes me feel good. Looking at the various procedures that are rank ordered by the tool, all of these procedures, you would agree, are given to people with myocardial infarction. So everything is looking good so far. I'm feeling good. search for echocardiogram, and I see echocardiogram is 30% on the top. But there's another code that says 0.2 or 20%. I just want to bring to your notice that what we're observing is a concept ID level information. This is, one procedure could be, or a diagnosis could be coded by more than one codes. This is at a code level. So this is like the least amount. So sometimes you will miss information because there are multiple codes that are capturing the same clinical idea that may not be presented up. Measurements. I filter by the measurement domain just to see what lab results. And you got troponins, prothrombin time, BNP, magnesium. All of these are related to myocardial infarction, which is good. Oh, running out of time? Okay. So we have catheter procedures. We have arteriosclerosis. Now, there are some bad signs. So when I was looking at it, I found certain procedures, like this procedure here was like there's some cardiac sampling of the ventricular of the heart, which did not make sense for a person with myocardial infarction. So I'm going to note that down too. There was some information that may suggest some index date misclassification. So there were people who received EKG just before they were admitted to the hospital. So that made me suggest that there's some index date misclassification here. There were some echocardiograms also. So you just observed an attempt to do a live review. We'll try to let you do it too. So the next phenotype is the idea of angioedema. We're done.
Yeah, so we have to be done. We're gonna have a break. But during the break, you could, if you want to, break and have fun. Or you can have more fun. By looking at the handout you received, it's telling you those diagnostics that you can use the app to look at. Each of these diagnostics can answer a few questions which are on the handout. So all you together on one table, you can pick one question to answer from the app, and that helps you understand what does it tell you about the angioedema definition that we implemented that also exists in the app. So you can do what he did, what Gowtham did for incidence rate. You can look at the incidence rate of angioedema, see if it's stable. Is it increasing with certain age? Is that what you expect, given that clinical description of angioedema? But basically, this is what we do after every time we create a phenotype. We do what we call large-scale characteristics of the people to see if what we see is consistent with what we expect, given the clinical idea. And this handout answers, put for you those questions and how the app can be used to answer.
Yeah. So please join us at the Phenotype Development Evaluation Work Group. So we'll talk more about this. There's a lot of advanced materials that we can cover for you in that workshop. And our goal for the next 1 year is to build a lot of phenotypes. So please join us. We would appreciate your support.